Welcome to the lecture series in high field MR at Kirby Center at Kennedy Krieger Institute and the Department of Radiology at Johns Hopkins School of Medicine. So as some of you may know, today's lecture is actually rescheduled from 2 weeks ago. And the reason is because we had some uninvited guests from last time, and probably due to overwhelming popularity for the speaker and the presentation. Looking back, I think it's an oversight on our part. So I do want to apologize for this to both the speaker and the attendees. So we have changed the setting for our Zoom meeting to make it more secure, and hopefully this won't happen anymore. So today the speaker is Dr. Peter Barker. And of course, many of us know him very well. And since we have done the introduction last time, and per Dr. Barker's request, we're going to skip our usual introduction. So we have more time to enjoy the presentation. So the title of the talk is 70 MR Spectroscopy of the Brain, Clinical Application ? So hopefully by the end of the talk, we can change the question mark to an exclamation or even better. So without further ado, Peter, looking forward to your talk.
Jun, thank you so much. I don't know that I've ever approached the lecture with such trepidation, actually, as hopefully with our new security measures in place, have any interruptions like we did last time. So I've also actually shortened my own introduction a little bit because I think some of you may have been here last time before we got interrupted. But just briefly to say there are about 90 7 Tesla systems in the world right now, either installed or planned to be installed. And this is a sort of similar size field to say to PET MRI scanners, where there are about 100 worldwide. And if you look at the number of publications, it's been growing steadily since the first systems were installed around 2000. You can see in the last couple of years, 2020, 21, sort of plateaued, and my interpretation of that is it's probably pandemic related, and hopefully the growth will continue now over the next few years. Very importantly, both the Siemens and GE 7 Tesla systems are now FDA approved, which means they can be used for clinical applications. This is our own 7T system being installed at the Kennedy Krieger Institute over 10 years ago now. And you can see what a major undertaking it is. It's a large magnet, requires a lot of helium to cool it down. In our case, in terms of sizing it, in a way we were lucky that there was a new building already planned, and so the 7 Tesla system basically occupies the whole of the basement level in this building. Because our magnet is an unshielded magnet, it also had a 400-ton steel shield built around it to limit the fringe field from the magnet. So this is really a major engineering undertaking. And the question is, well, is it worth we get significant improvement to say 1.5 or 3T systems to justify this extra cost and effort? So what are the theoretical advantages and disadvantages of 7 Tesla? Well, perhaps the most important thing is the greater signal-to-noise ratio. The stronger the magnet, the higher the signal-to-noise. So you can use that to make either shorter scan times or higher spatial resolution images. For MR spectroscopy, you have higher spec resolution. You also have greater magnetic susceptibility effects. So this is good for things like susceptibility mapping, susceptibility contrast, bold effect, things like that. But it's not universally good. So actually for MR spectroscopy, this is a disadvantage. Also, T1 relaxation times tend to be longer. So this is good for things like time of flight angiography, contrast enhanced angiography, arterial labeling. But for other types of sequences, it's maybe bad because it lowers the symptom noise. T2 relaxation times that tend to be shorter, so that also is typically not good for symptom noise. There are also some other things to consider. So there are increased physiological effects, such as vertigo, nausea, compared to lower field strengths, and I'll talk a little bit more about that in a moment. And there are just the engineering and technical challenges related to making homogeneous magnetic fields. You tend to need RF power compared to lower field strengths. And just the cost, as I already mentioned, is a significant issue in the adaptation of 7 Tesla into clinical practice. So this is one of the early scans that we did not long after our system was installed. So it's a 3D T1 weighted image with about 0.6 millimeter isotropic spatial resolution. And you can see these beautifully anatomical images with excellent gray white matter contrast. And so clearly anatomical imaging is something that works very well at high field. I just pulled these from the web. Here's an example of a MR angiogram done at 7 Tesla with 0.2 millimeter spatial resolution, about 10-minute scan time. Again, extraordinary detail to these vascular images. And this is MR venography done at 0.3 millimeter spatial resolution, an extraordinarily short scan time of just over minutes. So also clearly vascular imaging at 7 Tesla works terrifically well. From our own group, this is work of Chu Li in the KKI, who's been working with susceptibility weighted imaging and quantitative susceptibility imaging. And again, you can see these very crisp images here depicting the transmedullary veins very clearly in the SWI. And also quantitative mapping of brain and content using QSM, and you can see the dentate nucleus and the substantia nigra and red nucleus here beautifully well depicted. So again, another technique that works extremely well at 7T. One of the things we were asking is, well, so you get these very high resolution anatomical images, and what could that be useful for? And one of the early studies we did was looking at patients with temporal lobe epilepsy, typically imaged in the coronal plane, so you get a nice cross-sectional view of the hippocampus. And we developed this protocol, which had both T1 weighted images as well as T2 weighted images. The T2 weighted images are particularly nice, and you can start seeing this internal structure in the hippocampus, which is useful for analyzing the subfields of the hippocampus. And here's an example. This is a patient with right-sided mesial temporal sclerosis. The 3T clinical image on the left here was read as normal. And the 7T image, which is done at about double the spatial resolution, I'm not sure how well you can see, but it is definitely a much crisper image than the 3T image. This image, you can start to see loss of in structure, sort of fuzz to the right-sided hippocampus. And quantitative volumetric analysis showed that it was about 7% smaller than the left. And actually, when we looked at the subfields, the Ammon's horn was about 20% smaller on the right. And this is larger asymmetry than any asymmetry we saw in control subjects. So this was consistent with the clinical diagnosis of right-sided mesial temporal sclerosis. This patient went on to surgery and has been seizure-free since that time. So in this study, we did 11 patients in all, and 10 out of the 11 had unilateral mesial temporal sclerosis. One was bilateral. And then in 9 out of the 10 unilateral patients, 70 MRI correct lateralized the site of seizure onset. The important cases here are these 3 cases on the right-hand side here. These are the ones that were read as normal, considered normal on conventional 3T MRI. And in all 3 cases, 2 of the 3 were correctly lateralized by CT. So I think looking at patient flow of epilepsy is certainly one potential application for 7 Tesla MRI. And what are some of the problems? Well, one of the major problems is the inhomogeneity of the one field. This is kind of a fundamental thing because as we go up to higher frequencies, the wavelength of the RF gets shorter and becomes similar to the size of the human brain. So you sort of have this sort of standing effect. And if you sort of record an image with a transmissive type head coil, you see this central brightness in the middle of the brain. If you flip angle maps, you can see the flip angle is high in the middle and it drops off towards the edges, and also as you go lower down into the brain, into the cerebellum. So what are some of the consequences of this? Well, if you look at this image here on the lower right, which is a single slice I took from that Mp2 Range I showed you earlier, you can see, I think, that the gray matter intensity is not uniform throughout this slice. It's like brighter at the back than it is at the front in this case. This tends to mess up a lot of segmentation programs that are written assuming a sort of uniform signal intensity for the different tissue types. Just coincidentally, I also notice in this image there's some susceptibility artifacts adjacent to the mastoid air cells here. And these can actually trip up the unsuspecting radiologist, particularly if it's a contrast enhanced scan. They might confuse this for meningioma or something like that. So that's something to be aware of. So there are artifacts in 7T data. So how can we approach these problems? One way, which has received a lot of attention, is to use multiple transmit coils and attempt to generate a more uniform B1 transmit field. I would say that this is probably a rather disappointing area of research. This is a paper example I took from the literature. And you can see that these B1 maps, even after optimization with an element transmit coil, are still very inhomogeneous. You can certainly tune this so you can get excitation in the areas that you want. But because these elements all interact with one another, it's really not possible to generate a uniform RF field using multi-transmit. So another way of approaching the problem is to alter your pulse sequence to try and make it less sensitive to variations in the transmit B1 field. I think a great example of this is the Mp2 Range Sequence, where you start out with a regular Mp range and then you add a second readout at a different inversion time. And you can see if you choose your inversion times carefully, you can get the first readout where you have fairly strong T1 weighting. If you choose it around 1 second, you'll probably get gray matter or white matter signals of opposite sign. And then the second inversion time is more of a sort of spin density type image. And then you can combine these two images together in such a way that you remove a lot of the bias due to the RF transmit field. So here's an example of that. So here are the two different inversion times. Here's the calculated Mp2 range image, which hopefully you can see as somewhat more uniform signal intensity now. And then you can also generate quantitative maps of the T1 relaxation time as well using this sequence. So this is a way of making the images less dependent on the inhomogeneity of the V1 field. I also just note this short TI image is actually quite useful. You see this beautiful depiction of the cortical ribbon. This is proven to be quite useful, say in patients with subtle abnormalities such as focal cortical dystrophy. So this original image can be useful also. I just want to briefly talk about 7 Tesla safety. I promise I will talk about spectroscopy soon. This is obviously a very important area when you start putting patients into magnets. And perhaps the most important thing is that the FDA considers 7 Tesla to be a non-significant risk device. There have been some quite large studies done now of physiological effects of 7 Tesla. So in this one study listed here, they had over 3,000 patients. And about 20% of those experienced moderate and 38% experienced mild vertigo in the magnet. 5% had a metallic taste sensation, and then less than 1% had magnetophosphines, which is basically a flashing of lights in the eye. And particularly important is all of these effects are temporary and resolve as soon as being removed from the magnet. Another consideration is, are implants safe at 7 Tesla? A problem here is there's a lack of data on this, unlike at 3T or 5T, where pretty much every implant has been safety tested. Caution is required if you're putting a patient in a magnet who has some kind of medical implant. Many implants are safe, obvious things like dental hardware, cranial fixation plates, they're undoubtedly safe. But I think if you have patients with more critical implants, things like aneurysm clips, pacemakers, things like that, then those are patients who should not go into a 7 Tesla magnet. Just briefly, the origins of the nausea and vertigo. This is a study done by collaborators, David Z, Dale Roberts. Basically, this is an inner ear effect. So it's the magnetic field interacting with the naturally occurring ionic currents in the endolymph fluid. And this basically causes a lateral force inside the semicircular canals. This is the vesicular system, which controls your sort of autonomic things like eye movement and so on. And you can see that as the patient was being slid in, they started this spontaneous nystagmus. And it actually persisted throughout the whole time that the patient was inside the magnet. The velocity of the eye movement was dependent on the head position, and also the direction of the movement as well is dependent on the head position. And you can actually see that potentially it can be minimized by the right head position relative to the magnetic field. So this is why people do get this transient feeling of dizziness or even nausea when they go in the magnet. But it's well tolerated, and very, very few people really find this to be a significant problem. It's more of a nuisance than anything else. So finally, I'm going to talk about MR spectroscopy at 7 Tesla. And I think this slide really encapsulates why spectroscopy at 7 Tesla is good. If you compare the resolution of these 3 spectra going from 1.5T to 3T to 7T, you can see the lines get sharper. The signal to noise improves somewhat as well, although I'm the first to admit that these 3 spectra are not recorded under completely identical conditions, so maybe you can't read too much into the signal to noise of these spectra. But basically, at 7 Tesla, you start seeing compounds, some examples being like glutathione, taurine, inositol. Sorry about that. That are very hard to pick up at the lower field strengths. So I kind of like to think of 7 Tesla spectroscopy as giving you a survey of brain metabolism, all these different compounds. There's about 17 or so different compounds that can be detected potentially at 7 Tesla. So there are sort of neuronal type compounds, N-acetylspartate, NAG, which is thought to be a neuromodulator, and then neurotransmitters such as GABA and glutamate. There's also some evidence that aspartate might be a neurotransmitter. And then there's sort of compounds that are thought to be present more in glial cells, such as choline or myoinositol. And then there are things like antioxidants, such as glutathione and ascorbate. And then you have creatine, phosphocreatine energy metabolites. And then sometimes in some pathologies you can detect lactate, which is a marker of non-oxidative glycolysis. So this gives you a wide survey of brain metabolism. And I think in that sense it's sort of different from, say, PET imaging, where you typically have a PET tracer that you target one specific receptor or pathway. So I think this is complementary to other types of metabolic imaging, such as that. One particular advantage of 7 Tesla is the ability to distinguish glutamate from glutamine, which are very similar compounds and a very similar spectra. And you can see at 1.5 Tesla, there's almost total overlap of these two compounds. As we go to 4 Tesla and then to 7 Tesla, particularly this C4 resonance of glutamine starts getting quite well separated from that of glutamate. And as a result of that, you can estimate concentrations of glutamate and glutamine with much lower uncertainty than you can at 3 Tesla. So one of the early application studies we did not long after we got our 7 Tesla magnet, we particularly with this view on separating glutamate and glutamine, was to look at patients with pre-manifest Huntington's disease. So probably as most of you know, this is a progressive neurodegenerative disorder. It's a genetic disease. And so it can be identified by genetic testing. And there's this long period where patients are pre-symptomatic. They don't really start getting symptoms until they're about 40 years old. And then sort of slowly progressive that, death occurring 15 to 20 years later. And what's basically known is that even before patients are 40 years old, they start showing some mind symptoms, things like reduced cognition and so on, even before they get overt symptoms. And so there's probably neuronal loss or neuronal dysfunction occurring before the gross onset of symptoms. Of course, this would be good area to treat people before they sort of preventative treatment, if you like, before they develop the full-blown course of the disease. So we were interested in looking at this sort of prodromal phase and seeing if there are any abnormalities in neuronal type compounds such as glutamate or NAA in these patients. So this is the study. We had 12 patients. We had 12 age-matched control subjects. MoCA, Montreal Cognitive Assessment, you can see the patients did score worse than the control subjects. Just to give you some relevance, so the controls, this is a normal MoCA score. If you have a MoCA of around 22, you would be considered probably to have mild cognitive impairment. If you had a MoCA of 16, you would be considered to have Alzheimer's disease. So this is a mild dysfunction in cognition. We just looked at brain region, the posterior cingulate cortex, and basically what we found was both NAA and glutamate were reduced in the posterior cingulate in the patients controlled compared to the control subjects. But actually the reduction was stronger. Sorry, and then the NAA and glutamate also correlated with the MoCA score. There's actually a much stronger relationship statistically for glutamate with the MoCA score than NAA. And I'm increasingly thinking that glutamate may be a better neuronal marker, if you like, than NAA, which is traditionally considered the neuronal marker as measured by MR spectroscopy. Much of the rest of my talk, I'm going to be talking about schizophrenia now. And again, while traditionally, schizophrenia is thought of as a disease of the dopamine serotonin receptor systems, increasingly there's been a recognition that it may also be due to abnormalities in glutamatergic neurotransmission. And a lot of this comes from the concept of hypofunction of the NMDA receptor. By its name, is actually a glutamate receptor. And it was found sort of back in the 60s that drugs that are antagonists for the NMDA receptor, so such drugs as ketamine or PCP, which is also known as angel dust, they cause these dissociative symptoms, which are really similar to the positive symptoms that patients with schizophrenia exhibit. And in fact, this glutamate metabolism receptors are considered potential therapeutic targets. And there was a Lilly drug developed a few years ago, which unfortunately failed its clinical trial, but just illustrates the potential, at least, for making this a target for new therapeutics. So we wanted to really investigate what glutamate levels were in patients with schizophrenia using 7 Tesla MR spectroscopy. So this is a pretty large study that we did in collaboration with Akira Sawa in psychiatry at Hopkins. And here we're looking at actually patients' first episode of psychosis, or FEP. So here defined as anybody who was enrolled in the study within 2 years of their first symptoms of psychosis. And we had 81 FEP subjects, and we had 91 healthy control subjects. And we did quite an extensive protocol where we looked actually at 5 different brain regions using MR spectroscopy. In terms of how well the controls matched one another, well, they were pretty well matched with respect to age. In terms of gender, there were more males in the FEP group, and this actually reflects the prevalence of the disease. It's more common in males than females. And then a number of other confounders as well. So these subjects tended to have fewer years of education, they smoked more, they had a higher cannabis use, and of course they were also medicated, whereas the controls were unmedicated. And they had similar Q levels, although again the controls were slightly higher than the patients. Very significant were on neuropsychological performance, all these different areas of performance. The patients scored much worse than the control subjects in all areas. So this is an example of representative spectra. There are 5 different brain regions looked at. So the thalamus, orbital frontal region, anterior cingulate, and dorsolateral prefrontal cortex, and the centrum semiovale, which is a white matter region. And these were all picked as regions that have, there's evidence from one source or another that they may be involved in patients with schizophrenia. And you can see we got nice high-resolution spectra, at least from these three brain regions. Spectral quality tended to be worse in the thalamus and orbital frontal region because of the susceptibility effects there. So here are the results. And I think it's pretty easiest just to look at the chart on the right here. So here are the 5 brain regions. Sorry about that. So there's the anterior cingulate, CSO, dorsal lateral prefrontal cortex, orbital and thalamus. And then we selected relevant metabolites, GABA, glutamine, glutamate, glutathione, NA and NAG. And if it's red here, this means that it was higher in the patients. And if it's blue, it's lower in the patients. And if it reached statistical significance, there's an asterisk marking that. So a couple of things you can see here. So first of all, the anterior cingulate seems to be an important region where most of the spectral abnormalities were found in the anterior cingulate. Also, you can see that NAA was reduced and NAAG was reduced, although it didn't reach statistical significance. And glutathione was also reduced as well. And glutamate and GABA were also reduced. So it seemed like most of the neuronal compounds, such as GABA, glutamate, NAA, were increased, even though these patients are quite early in their disease course. So this indicates there's maybe some neuronal damage or dysfunction even early during the course of psychosis. And also interesting that glutathione was reduced, and there's quite a lot of theories about oxidative stress, potential mechanism of the pathogenesis of schizophrenia, and this provides some support for that theory also. So we looked at this data in various different ways. It's quite a rich data set. Now, interestingly, these patients with FEP, about 20 to 30% of these patients are basically treatment resistant and have to try multiple antipsychotics in an attempt to control their symptoms. Whereas other patients may respond well to treatment and actually effectively be almost cured. So we wanted to see if there was anything in this data that we could use to predict who would be treatment resistant versus who would respond to treatment. And I should say we have follow-up in these patients for up to 5 years, so we do know the final outcome, if you like, in nearly all of these patients. So when we looked at the differences between those who considered treatment resistant, so those basically failed 2 different antipsychotics or were on clozapine, which is kind of the antipsychotic of final resort, if you like. It's effective, but it also has quite a lot of side effects. And the patients who were treatment resistant, they tended to have a younger age of onset than those who responded to treatment. They also had more severe negative symptoms, and this is something which is actually well known from the literature. When we looked at the glutathione levels in the ACC, the FEP patients as a whole had lower glutathione than the control subjects. And then the treatment-resistant ones actually was significantly lower glutathione than the responsive ones. So this points to oxidative stress as potentially being not only a source of the pathophysiology of FEP, but also perhaps also pointing to it being a cause of treatment resistance as well. Interestingly, you can make a sort of ROC curve like this to predict who is going to be treatment resistant, who isn't. If you combine some of the parameters, such as the age of onset, glutathione levels, a couple of volumetric measures from brain MRI, put them all together, you can actually get quite a good model for predicting who's going to be treatment resistant. And that could be potentially useful for deciding how to treat a patient, maybe going to a stronger antihistamine earlier if you have a suspicion they're going to be treatment resistant. Another thing we looked at was the final diagnosis of these FEP patients. About half of the population ended up with a diagnosis of schizophrenia. And then the next largest group was patients who ended up with a diagnosis of bipolar disorder. And so again, we thought it'd be interesting to compare at baseline, were there any significant differences between the schizophrenia and bipolar groups? And in particular, it was found that glutamate was significantly different between these two groups, with it being lower patients with schizophrenia. So again, this could have some use in predicting what the final diagnosis is going to be, and different drugs are used to treat these two different diseases. And that the fact that glutamate is lower also suggests that there may be perhaps a greater degree of neuronal injury early on in the patients with schizophrenia compared with bipolar disease. So these patients, as I mentioned, we have up to 5 years follow-up in them, and they were getting annual scans wherever possible. So we were able to look at the rate of change in metabolites over time in these patients as well. So we, obviously not all patients got follow-up, so we had a somewhat smaller population. So we had 38 FEP patients and 48 controls who had multiple follow-up scans. And then we took metabolite levels over time and calculated percentages per year for each of these metabolites. So for instance, we look at NAA, we found there was a significant decrease in NAA with time in the patients, but not the control subjects. Similarly for GABA as well. Interestingly, in glutamate, we actually found reduces in glutamate over time in both the patients and the controls, which is a little bit surprising to us. We didn't expect too much changes in these sort of young adult control subjects over time. But the rate of reduction in the patients was greater than the rate of reduction in control subjects. So NAA glutamate declining over time suggests that there's neuronal injury ongoing in these subjects. Two other findings which were quite interesting to us, that glutathione, remember glutathione was low at the initial scan and it stayed low, but it didn't decrease any further over time in either the patients or the control. And then a somewhat unexpected finding for us actually was we also found a decrease in choline over time in the patients that we didn't see in the control subjects. And actually choline is sort of interesting because it's actually in the compound, it's an acetylcholine precursor. You need it for the synthesis of membrane lipids. And actually, a few previous cross-sectional studies of schizophrenia also reported low levels of choline. We get most of our choline from our diet, actually, things like eggs, vegetables, and meat. And I do wonder if these patients with FEP, a lot of them have unhealthy lifestyles and probably poor diet. And I wonder if there's a dietary component to this reduction. But it's also interesting, actually, that a deficiency of choline in utero is known to be a very significant risk factor for the development of schizophrenia. And there's some historical background to this. So the so-called Dutch hunger winter of 1944, 1945, at the end of World War II, where there was sort of mass starvation of the population. And you can see this is the incidence of schizophrenia in Holland, according to the in utero. You can see there's this large increase in schizophrenia corresponding to that time period. Actually, since 2017, the American Medical Association has been recommending choline supplementation during pregnancy for this reason. So the last schizophrenia study I want to talk about is in a different cohort of subjects where we're looking more at the chronic schizophrenia population. And this was a study we did in collaboration with Laura Rowland over at University of Maryland, where they have a very well controlled and highly studied cohort of patients with chronic schizophrenia. And so we looked at patients with schizophrenia, some of their first-degree relatives who often have similar traits to the patients, but not so severe that they actually have a diagnosis of schizophrenia, and therefore also tend to be unmedicated, as well as a matched group of healthy control subjects. And you can see now, whereas previously we were talking about subjects in late teens, early 20s, now we're talking about subjects who are mid-30s average age. Again, some of the differences between the cohorts. So again, years of education are fewer in the patients with schizophrenia. The patients with schizophrenia do much worse on measures of cognition, whereas interestingly, the first-degree relatives are basically the same as the control subjects in terms of performance. And then we looked at these patients. We had a somewhat unexpected finding. So these are violin plots of the brain glutamine levels, again in 5 different brain regions. And it has significance in 2 regions, but there's a general trend actually across this data for glutamine to be higher in the patients with schizophrenia than either the first-degree relatives or the control subjects. This was somewhat unexpected. We didn't really expect to see changes in glutamine, and we actually didn't see much in the way of glutamine changes in the FEP cohort. So another thing we did with this cohort was we looked at those patients who had short disease duration, with short being less than 5 years versus the disease duration, which is greater than 5 years. And of course, the subjects with the longer duration will tend to be older also. And by definition, they have a longer illness duration, of course. And also, of course, they have a higher cumulative antipsychotic dose as well, just because they've had the disease longer. And there were 2 significant findings out of this comparison. So one was glutamate was lower in the long disease duration, again, indicating neuronal damage or dysfunction increases with longer disease duration, and perhaps longer use of antipsychotics as well. And then a second somewhat unexpected finding was that we found that actually lactate was also increased in this long disease duration group. So what does all this mean? Well, the glutamine finding is sort of interesting. Obviously, glutamine cycle is extremely important in terms of neurotransmission, and glutamate gets released into the intrasynaptic cleft, and it gets taken up by the astrocyte, where it's converted into glutamine by addition of ammonia coming from blood vessels, and then transported back into the presynaptic neuron, where it's converted back to glutamate. So a lot of things could be influencing this cycle. So there could be abnormalities in uptake of glutamate, basically perturbed glutamate cycling. It's also possible that if there's increased ammonia in the blood, that may also drive glutamine synthesis. And we actually just have a new R21 grant now where we're specifically examining that hypothesis about blood ammonia driving glutamine synthesis. In terms of the lactate finding, well, maybe it indicates some mitochondrial dysfunction in the long illness duration group. And there have been a few papers in the past suggesting abnormal mitochondrial function in patients with schizophrenia. And actually, a kind of theory I like is that if you delve in a little bit into metabolism, you can actually come up with a link between lactate and glutamine. If you have increased alanine transaminase activity, so that converts alpha ketoglutarate to glutamate, that also generates pyruvate, and then pyruvate can go to lactate, and glutamate can go to glutamine. So possibly upregulation of ALT might be another mechanism causing this finding. So these are all things we're going to be investigating in this new R21 grant that we're just starting now. So we've done a lot of work on schizophrenia. I think it's important to recognize the limitations of these studies. So these are all pretty subtle metabolic differences. So it's good to use 7 Tesla to study them, but it does place pretty stringent demands on the spectral quality and also the accuracy of the quantitation techniques. One should remember that spectral quality varies by region, particularly low down in the brain. So you may not get significant findings in some of the more inferior brain regions. It's not because those regions are necessarily normal, but it may just be that the measurement is not good enough to pick it up. All of these studies have confounding factors such as medication use, smoking, marijuana use, etc. And it's pretty difficult to control for these. And unmedicated patients are very rare, particularly in the USA. So it's very hard to find unmedicated patients to study. And then finally, just in terms of interpreting compounds like glutamate and so on, one should remember that we're measuring the total metabolic pool of glutamate. We're not looking at neurotransmitter levels. So that's always important to remember in entering the data. So I'm going to switch gears a little bit. I think I have about 10 minutes left. So I'm just going to briefly talk about brain tumors, and an area of great interest currently, of course, is the discovery probably about 10 years ago of mutations isocitrate dehydrogenase, which seems to be a very important factor in brain tumor metabolism. And I already showed you in a previous slide the TCA site. So IDH converts isocitrate to alpha ketoglutarate, as you can see over here on the right-hand side. And when you have a mutation in the IDH enzyme, basically what happens is a proton gets added to alpha ketoglutarate, and that converts it into 2-hydroxy glutarate. And this is reported to build up in millimolar quantities in patients with gliomas with this mutation. And so it's potentially detectable using MR spectroscopy. So it could be a non-invasive way of diagnosing IDH mutation status. And so why is it important? Well, it's important for a couple of reasons. One is prognosis. If you look at these Kaplan-Meier survival plots, various different types of glioma, low-grade, high-grade, without the IDH mutation, by far the gliomas with the best survival are the ones with IDH mutations. So it's a prognostic marker if you have the IDH mutation. In fact, if you have IDH mutation and 1p19q, you likely have the longest survival. So these are so-called traditional oligodendrogliomas. So it's important for prognosis, but it's also now a therapeutic target. And there are a couple of IDH inhibitors out there. There's one for IDH1, Tibsovo, and one for IDH2. And these are actually FDA approved, not for glioma. They're approved for leukemia and the body too, but there are clinical trials now ongoing in patients with glioma. And certainly you could imagine some potential applications of non-invasive measurement of 2-HG, for instance, selecting patients who might best respond to these treatments or monitoring the effects of the treatments. These treatments are designed to reduce flux through IDH. So where does 7T come into this? Well, this is a study done by my former postdoc, Adam Barrington, where he had, I think it was 9 patients with glioma who were scanned at both ET and 7T. If you look at these example spectra, it's not an easy compound to measure because it's fairly low intensity and it overlaps quite a bit with other compounds such as glutamate, GABA, and so on. And you can sort of refine the acquisition technique to try and maximize the sort of selectivity of detection of 2-HG. And in this example here, at 3T, the 2-HG was fit with a 15% uncertainty, whereas at 7T, it was fit with a 6% uncertainty, a more accurate measure. And this is a plot for all 9 patients, the 2-HG uncertainty levels, the tremor around lower bounds, significantly lower at 7T than 3T. And also they had 1 false positive when they did the study at 3T, but there were no false positives at 7T. So this is the potential clinical application for diagnosis of IDH mutation status in patients with glioma. Just finally, I want to very briefly talk about spectroscopic imaging at 7 Tesla. This is perhaps also a cautionary tale for young scientists who are listening to me. So this was actually back in 2005, before we had our own 7 Tesla scanner here at the Kirby Center. And so we traveled to Cleveland, the Philips factory in Cleveland back in 2005 to try and get some preliminary data for a grant application. And we put the normal volunteer in the magnet, and I used my 3T MRSI protocols unmodified. Just tried it on this normal subject. And I was very impressed by the spectral resolution that we could get at 7 Tesla. And in particular, I could resolve the NAAG signal from NAA, which is something I'd never previously seen at 3T. And we were able to generate maps of choline and creatine and glutamate and so on. And but we actually never published this because it was just a sort of N=1 example, and it was a very poorly optimized protocol. But of course, we should have published it because it would have been, I think at that time, the first reported 7 Tesla MRSI scan of the brain. So it just shows that publishing is important, even if your data is imperfect. Since then, of course, the methodology has been vastly improved, particularly work done in Vienna by Wolfgang Bogner's group, who have really, I think, pushed this methodology to great heights, new heights. And here you can see examples of metabolic at 7 Tesla from glutamate and choline and glutathione and so on, depicting very nicely the gray-white matter differences, and also this is at pretty high spatial resolution. And they've also been now applying this to patients with brain tumors, and you can, I think this is actually an example, I think, of the power of spectroscopic imaging in patients with brain tumors. I just draw your attention to this choline map here. You can obviously see on the conventional MRI scan the lesion in the right hemisphere, but you can also see on this choline map how this high choline, which presumably represents infiltration of tumor into the contralateral hemisphere. And also you can see the same thing on the myo-inositol map. Interestingly, this is not picked up on a methionine PET scan, which is one of the state-of-the-art PET techniques for imaging brain tumors. Also interesting is the increasing glutamine in the tumor, and glutamine is one of the sources of energy metabolism for tumors. So I think actually being able to measure glutamine in brain tumors is going to be very important too. So I'm going to just stop there and wrap up. Basically, to summarize, I think 7 Tesla is an excellent tool for neuroimaging, neurological, psychiatric, oncological applications. And I think particular strong points are metabolism and brain anatomy. I think it's particularly good for some of these harder to measure compounds in the brain that we have a tough time measuring easily at lower field strengths. But I also should mention that it's good for vascular imaging and it's good for susceptibility mapping too. So I think we're at the point where we're at the beginning of a new era of 7 Tesla in clinical practice. But I think the high cost is definitely a significant problem. And perhaps for now, this will mainly limit it to major research sites rather than more general use. But perhaps with future developments in magnet technology, the cost of the magnet will come down and then it may become more widely available. So I'm going to start and thank you very much for your attention, and I'm happy to answer any questions if there are any.
Thank you so much, Peter. This is a great talk, I really enjoyed that. So now we are open for questions. And so the way we do it is please put your question in the chat box, and then I read the question so Peter can answer. So we got first question. Do you have a suggestion for overcoming field inhomogeneity in whole brain MRSI at 70?
That's a great question, very important point. I think the B0 homogeneity problem can largely be solved through use of these local shim coil arrays or combined, RF B0 multi-channel head coils. I think in the future that's largely going to be solved. I think the B1 inhomogeneity, transmit B1 homogeneity is a tougher problem. It's more of a sort of fundamental wavelength thing, and so I think there, it's a question of trying to make your sequence insensitive to the effects of it inhomogeneous transmit B1. But certainly, it's that is a problem right now. Trying to get wide coverage, making the fields homogeneous enough. So it's a good question.
Yep, thank you, Peter. So, yeah, so the second question, how did some of the long-term schizophrenia patients get recategorized into the bipolar disorder pool? Was this a clinical decision?
Right. Well, first I want to say hi, Bob. Thanks for your question. Yeah, so so I should be clear that the initial diagnosis was not necessarily schizophrenia, but they were basically had psychotic episodes. So that's why we called it the FEP group. We didn't call it schizophrenia group, but yes, that's purely a clinical classification, based on symptomology, and I probably don't know enough about that as I should do, but it's a clinical diagnosis.
Yeah, Peter, I actually want to follow up with the first question. So I was wondering, thanks so much for the answer. So I was wondering, you mentioned that, I agree with you, B1 is probably much tougher than B0 in terms of inhomogeneity. So you mentioned that, the parallel transmit idea, it does not seem to pan out very well, currently. So I was wondering, what's your opinion, looking forward, which might be, the way to go to sort of trying to tackle this very tough technical challenge?
So I think the parallel transmit. I'm actually very happy that we have the parallel transmit, because it allows you to tune the B1 field that you sort of can't do with the sort of conventional transmit setup. So you sort of end up, you can put more B1 into specific regions of the brain that you're interested in. So that's a good thing, right? But I think that what we really want, of course, is a very uniform field. And I don't have any suggestions for how that would be possible. Hopefully SMART's going to come along with a way of doing it, but I haven't really seen anything in the literature yet that convinced me that, I think you can do a little bit better with multi-transmit in terms of uniformity, but it's not to the, we know when we put somebody in a 1.5 or 3T scanner, you get these almost sort of flat bias fields, whatever, and we're just not approaching that at 17. I haven't seen any way of doing that. So,
right. Yeah, we get a question from Paul. So you show many changes in these metabolites in different disorders, for example, glutamate in Huntington disease. But what is the theory that this association is actually associated with the disease? It seems like phenomenology without the theory of the biochemical changes. Many of the changes, the theory is neuronal loss, but how is this helpful in terms of course of treatment?
Well, I think that's absolutely right. I mean, I think we're probably a lot of the time, if we're seeing changes in NAA or glutamate or GABA, this is probably sort of a downstream effect from the actual cause of the disease. So, if NAA goes down, it doesn't really give you any information about, the direct biochemical cause, but it perhaps gives you a marker of how much neuronal loss or dysfunction is going on. I think perhaps one compound which is different is glutathione as an antioxidant, and that is potentially could be very directly related to cause. Oxidative stress and so on, and actually there are a number of studies ongoing, for instance, using N-acetylcysteine to try and reduce the amount of oxidative stress, and potentially also monitoring the effects of N-acetylcysteine. Does that cause an increase in glutathione in the brain?
Yeah.
So there's a question from Chan. Okay, so do antioxidants work? I think that's work in progress. I think there's I think in schizophrenia, I think the evidence is sort of not particularly good. But one problem may be N-acetylcysteine doesn't get into the brain, so if you do it, administer it orally or intravenously, but some recent studies have looked at intranasal administration. That's sort of a popular route right now for trying to get drugs into the brain. So those are studies that are still being done. Shan has a question. What extent does blood influence MRSI? Well, I mean, the vascular volume in the brain is very small, right? It's a few percent. So in a normal brain, the composition of the blood doesn't really affect the brain signal much. Obviously, if you have hemorrhage and so on, if you then typically there are large magnetic susceptibility effects with hematomas and things like that, and that basically makes it impossible to do MRSI in those regions. So, hope that answers your question. It's a question from Andreas. Further increase in SNR spatial resolution. What could the increase in multi-channel array system add to these factors? So yes, I mean, the higher the symptom noise you have, you can go down to smaller regions, and then that actually should improve the homogeneity. A smaller volume is more homogeneous. I think it's important to remember that there are sort of two things that control line widths in spectroscopy. One is the macroscopic field inhomogeneity, and that as you go to smaller volumes, that will improve. But there's sort of the natural line width, if you like, which is sort of a microscopic susceptibility effect, and that doesn't change with the voxel size. So I think at some point you sort of reach a plateau in terms of spatial resolution. It's quite hard to improve spatial resolution because you need to, if you half your voxel size, that's in a linear dimension, that's like 1/8 the volume, right? So there's a steep slope of losing symptom noise. So yeah, Shan just clarified, she meant if there's a hemorrhage. Yeah, well, hemorrhage is bad news for spectroscopy. Usually you can't do spectroscopy in a hemorrhagic lesion or in close proximity to it. So. All right, I think we're out of time.
Right.
So
thank you again, Peter, for this. Yeah, for this wonderful talk. If no other questions, we'll conclude today. Again, we'll do the normal time, which is the first Tuesday for next month. And also, I want to mention that assume people who attend this lecture series are interested in high field MR research. So the RSMR, high field study group is organizing a wonderful workshop in March on this topic. So I hope to see many of you there. Thank you again. Thank you, Peter.